Well, while we're doing that, I'll go ahead and get started. So I'm Tess Baylor. I am founder of Renegade Research, the group here that is a nonprofit that is studying ME/CFS and long COVID. We're patient-led, and we are organizing community science projects to do distributive self-experiments and pool data to try to be able to do research that is difficult to do in standard systems. And our largest project, Remission Biome, is one of the main things that we're working on right now. And you can go to the website remissionbiome.org to sign up to get our newsletter and be updated about Remission Biome and Renegade Research and all of the talks and everything that we have happening. Panelists are part of our team. This is not everybody that's on our team, but I just wanted to recognize everybody that is here. And I'm going to have everybody wave. Ellie suggested that, so we'll wave to everybody. So I mentioned the upcoming talks. We have different types of talks, and one of the new types that we're starting is the clinical roundtables. And I'll have Isabel give a little pitch about that.
Yes, thank you everybody for being here. Our Clinicians Roundtable will start March 15th at 1 p.m. Eastern, will be the first one. And you will have the link to register for that posted. The first one will be with Dr. Rowe and Dr. Kaufman. And the purpose of the Clinicians Roundtable is to give expert clinicians treating ME/CFS, long COVID, and post-infectious conditions an opportunity to explain their practice and how they approach the complex patients that we are, and have other clinicians learn what they do and hopefully expand the pool of clinicians treating these conditions, as well as having patients learn as well and bring the information to their providers. And again, the purpose is to expand the pool of providers who are helping us and treating us as patients. And yeah, so welcome, and we hope to see you there.
And I'll mention we have another roundtable in the works. We don't have the link for it yet, but with Dr. Gillette and Amy from Barcelona, who Isabel and I just got to meet last week, and they do work that's related to what Dr. Rowe is talking about. So that'll be another good one in April. So if you go to remissionbiome.org and sign up for our newsletter, you'll get that link when it comes out to register for it. The other type of talks that we'll have coming up are research roundtables. And these are ones that we had been doing internally within our team to discuss science, mostly related to remission biome and hypotheses of what might be happening during remission events. And it's been a really awesome meeting, bringing together researchers from all the different fields. And it had been invite only, but we're going to be opening these up to the public. So look out for announcements about that, and it'll be fun to join for people who want to know more about the research and see some of the behind the scenes discussions. I have a quick poll that I'm going to do before we jump in here. So the poll should pop up. Just kind of want to get a feel for who's in the audience right now. So we have about half of the answers so far. A lot of patience again. And we have a pretty knowledgeable audience, knowledgeable about these specific topics. So almost to the end here. All right, I will end it now. Yeah, so we have 77% are patients. We have caregivers and friends and family. We have 5 clinicians here and 11 researchers. And for how much you know about these conditions, we have about 50-50 know a lot or some. We have a few people who know very little about it. So we'll have a kind of wide range of of questions at the end to try to make sure that everybody comes out of this with a lot of knowledge. Okay, so I will now introduce Dr. Rowe. He is the director of the Children's Center for Chronic Fatigue Clinic and a professor of pediatrics at Johns Hopkins University, with research interests including ME/CFS, fibromyalgia, Gulf War illness, pelvic congestion syndrome, hypermobility syndromes, including EDS, and orthostatic intolerance syndromes, including POTS. SolveME honored Peter Rowe in April 2023 for his work as a provider, researcher, educator, and advocate for ME/CFS and long COVID communities. And if you were here last week, you will know that he is an excellent presenter and just we're very grateful and fortunate to have you here. So we're looking forward to this, and I'll pass it off to you, Dr. Rowe.
Great. Well, thank you for having me back. I just want to share these slides. Let's see. So I'm disabled on screen sharing for some reason.
Try again. I think I just
Here we are. Okay, good. All right. So we had the talk last week, and that focused primarily on the issues of orthostatic intolerance and some of the vascular compression syndromes and how they interact with the orthostatic intolerance piece. And today I'm going to spend most of the time on movement restrictions and biomechanical factors, which are things that we've been interested in for about 20 years, but have not caught on as much as I would have hoped with other researchers. And then I'll be talking about the neuroanatomic problems. I mentioned that I'd be talking about mast cell activation today, but just from time constraints, it'll really be something we only touch on a little bit with each of the patient stories. And I'll try and illustrate most of these problems with true patient histories. So let's start off with the biomechanical issues that include thoracic outlet syndrome. One of the things that we noticed a long time ago is that many of our adolescent patients came in with postural abnormalities and movement restrictions. So you can see in this picture, this young man had a lot of rounding of the back, a kyphosis. And when you look at his head, he has a very head forward posture that's not very conducive to proper ergonomic posture. The best position to be in is to have your head straight above the spine and well supported. And the further it's out over the away from the spine, the harder it is to maintain the head position. We also noticed that a lot of our patients would have limitations and get stretch at an early point on things like straight leg raising or bending their ankle backwards or lying flat and bringing their leg up. And the boy on the right was unable to get his leg any further than this without getting anterior thigh stretch. And then when we would send people to the physical therapists that we worked with, it was interesting that the patients would call us the next day or two and say, am I supposed to be this tired? And we knew by that point that these manual physical therapists, so they were doing very gentle forms of physical therapy, could get people better after a few sessions, but the first couple would stir up their symptoms. So we started wondering what was going on, because this seemed really important if we could understand the pathogenesis of symptoms of ME/CFS. And what they were doing in their initial assessment was just doing range of motion tests. So we thought, let's bring in a couple of patients. And our initial thought was that what they were doing was somehow disturbing their orthostatic blood pressure and cerebral blood flow control. So we thought maybe these range of motion tests, like the straight leg raise, are causing some kind of change in heart rate or blood pressure like we were seeing on the tilt test. So we said, let's bring somebody in and we're going to lift their leg to 10 degrees for 2 minutes, measure heart rate, blood pressure, pulse oximetry, skin temperature, and symptoms, then go to 20 for 2 minutes, 30 for 2 minutes, and so on. So the whole test was 12 minutes and the patient wasn't really doing any work. So what happened? Well, here you can see one of these patients who had only mild to moderate ME/CFS. He was still able to attend college, He came in with a fatigue score of about 5.5 out of 10. As we went up on his leg, by the 30-degree point, he was having increased fatigue. He was having some further cognitive fogginess, really much more by 40 degrees. At the 60-degree point, we brought his leg down, and this guy could not leave the physical therapy office that he'd originally driven to for another hour. It really sort of flattened him. And notice that lightheadedness in the blue got worse as well, even though lifting somebody's leg ought to improve the amount of blood getting back to their heart and actually reduce the lightheadedness. So we saw cardinal features of ME/CFS being reproduced. And this introduces a concept that's well known in physical therapy called neurodynamics. And it's the interaction of the nerve mechanics and nerve physiology. The point being that as we move in daily life, the bones and the muscles and the joints and the connective tissues impose forces on the nerves. And with movement, the nerve tissues have to elongate, they have to slide and angulate around joints. And as part of the elongation, they undergo some compression. With mechanical stress to the nerves, you can get other physiologic responses. And when this is happening in an abnormal way, the abnormal neurodynamic interactions first were called adverse neural tension, which is a term you'll sometimes see in the physical therapy literature. And later people said, well, you don't really know if it's true nerve dysfunction. Let's call it neurodynamic dysfunction or neural tension dysfunction. There's still a bit of argument about these terms. But to give you an idea about this, people who've done a variety of anatomic studies have also shown that the nervous system has to adapt mechanically as we move. So if you go from a full back bend position to a full forward flexion, the spinal cord and the canal length has to increase 5 to 9 centimeters. If you look at the median nerve in the arm, when we have our arm in a position of flexion, it takes 20% of a length difference, an elongation, to get to full extension of that median nerve. This is a picture by neurosurgeon Alf Brieg from Scandinavia. They were doing cadaver studies, and here's the cadaver in the position of spinal flexion. This is the spinal cord and the nerve roots coming out, and you can see they're sort of slackened. This is extension. And then with flexion, where the spinal cord has to elongate, you can see things are much tighter and taut, including the blood vessels. So there's a lot of change that goes on even in the spine, just from flexion to extension. This is a slide showing that when you elongate that nerve, you're also getting this kind of effect that you'd get with one of those little finger toys, puzzle toys. So you're getting some compression midway through that nerve. And so I thought it might be helpful for people to get a sense of what we mean by neurodynamics. And if you have ME/CFS, you might want to not do this. But the next few slides, if you're feeling okay, you might want to sort of participate with. So my wife was kind enough to do the modeling for this. And if you start with your arm like this, and then extend it, most of us will get a bit of pulling across the top of the elbow here. And then if you, so that's some neural tightness. If you then lean your neck over towards the area that's tight, often that lessens the degree of stretch. And if you go the other way and take more slack out of that system, it usually increases the stretch. And you can increase that further by turning your wrist down. So that illustrates the fact that we all have a certain degree of neural tension, right? It's not, the nerves are not just rubber bands that can stretch infinitely. What happens is if you've got abnormal tension within the nerves, then the muscles around those nerves will tighten up and contract to stop you from stretching them beyond where they're comfortable. That in turn increases the amount of energy expenditure you have to give because you're working against your own muscle contraction. You can see reductions in blood flow to the nerves and changes in electrical conduction of the nerves as well as swelling in the nerves. And all of those changes can lead to more sensitivity of the nerve to different stimuli. We also know from the literature that you can get increased autonomic nervous system responses. So people with abnormal tension within the nervous system can get sweating. They can get altered blood flow to the tissues that those nerves are supervising. And it's very important to note that this can lead to neuroinflammation, the release of inflammatory neuropeptides. All of these are sort of familiar terms in the ME/CFS pathophysiology literature. We wanted to study this a bit more carefully. And so with Kevin Fontaine, who's shown on the bottom, and Rick Violand, who's my physical therapist, educator, and collaborator for the last 25 years, we decided in a study that was funded by the Solve ME/CFS initiative to do a randomization of 60 patients to a neuromuscular strain and a sham maneuver and 20 controls to the same things. So what we were looking at was the symptom intensity differences between baseline supine posture before we did the maneuver and the 15 minutes of straight leg raise, or 24 hours after the maneuver. And we were looking at 5 of these symptoms on a 0 to 10 scale. So fatigue, body pain, concentration problems, lightheadedness, and headache. And we summed those scores to create a combined symptom score. And we also looked at the proportion who reported at least one symptom increase in intensity of 2 points. So what did we find? Well, when we compared the CFS strain group, remember they're having a straight leg raise, and we positioned this so that each individual would have a slightly different but individualized strain, halfway between the point at which they reported stretch initially and the point at which they were at end range for that straight leg raise. So halfway between, so it was a good stretch, but not painful. And when we subtracted the scores of the strain from the sham group, who had only a towel under their leg, so not more than a 5-degree elevation of their leg, what we saw acutely during the 15 minutes of straight leg raise was increased pain and problems with concentration in the ones who had the true straight leg raise, and their total symptom score was much higher than that of the sham group. Then we called them 24 hours later and said, what's the difference now? And 24 hours later, they had increases in lightheadedness and in the total symptom score, suggesting that this simple maneuver was capable of triggering post-exertional malaise. Here's an example of somebody who's rating their symptoms on a 0 to 10 scale. Here's lightheadedness, baseline supine, 5 minutes into the straight leg raise. The score is going up. It goes up at 15 and is even a bit higher in the few minutes after the test. Headache went up 1 point. Body pain went up about 3. And fatigue went up 2 points. So this person had a number of symptoms that were aggravated by this maneuver. When we looked at the number of people who had a symptom that increased in intensity by more than two points or more during the maneuver, 80% of the strain patients had at least one symptom get worse. About 60% had 2 symptoms get worse, and about 45% had 3 symptoms get worse. Now, some of the people in the sham group also had increases in symptoms, we think in part because they had to come in from their cars to the research setting. And so we were provoking some day-to-day increases in symptoms as well. One of the patients who was a PhD student said later, today's the first day, this is a week afterwards, today's the first day I'm feeling better from the study, but I'm still not feeling great. I was in a lot of pain all weekend. My whole body hurt. I was exhausted but couldn't sleep. I wasn't capable of holding a coherent conversation or making decisions all weekend. Friday, I was emotionally unstable and cried a lot, also nauseated and couldn't eat. I'm still having more brain fog than usual. So we didn't formally study the 1 week outcomes of this, but clearly some patients really had quite prolonged symptoms afterwards. So we concluded that a longitudinal strain applied to the nerves and the soft tissues around those nerves in the lower limb was capable of increasing symptom intensity in people with ME/CFS for at least up to 24 hours, confirming our preliminary observations in the college students that increased mechanical sensitivity is a contributor to symptoms in this disorder. What might have been happening to cause symptoms, and because they were so immediate? Well, there was a bit of a help from this paper from 2016 where they did a sham straight leg raise and then a normal straight leg raise, and they measured where the lower part of the spinal cord was on an MRI machine. With the sham, you get no real change in where that spinal cord is located. But with a true straight leg raise, the spinal cord goes down 3.5 centimeters. So you're transmitting this stretch to the cord, and that could have been somehow implicated in the increase in symptoms. The mechanism for the translation of strain into symptoms is unknown, but my feeling is that whatever it is neutral with regard to the hypotheses about the causes of ME/CFS. So you could, for example, have a lot of swelling of the nerves after an infection, or if there's an immune response, you could get changes in the nerves or the brain. The mast cells we know respond to stretch of the skin, and maybe the mast cells in the nervous system were responding and releasing products that caused symptom exacerbation. It could be that the nerves are not as stretchy as the ligaments, so when they're going across hypermobile joints, they're overstretched, and there could be some other stress on the spinal cord and the peripheral nerves. We really don't know the answer to this question, but we next tried to look at how prevalent these problems were in our adolescents, and this was a cohort study we did with Drs. Fontaine and Rick Violand, as well as a number of summer students that worked with us. And what we came up with was an 11-point assessment of range of motion that added the ankle dorsiflexion on each side of the body, passive straight leg raise on each side, prone knee bend, and seated slump test, and the upper limb neurodynamic test, and then also a prone press up like you see in the bottom right. Here's the seated slump test. This is a test that actually takes all of the slack out of the nervous system. You sit straight up and then you slump, which rounds the spinal cord and elongates it. You anchor it by bringing the head down, and then the patient tries to bring the leg up to horizontal. And an abnormal test is when they can't bring the leg fully upright or when they start getting symptoms from this. The upper limb neurodynamic test is something that's used to evaluate the brachial plexus of nerves that come out of the neck and down into the arms. So it puts strain on usually the median nerve, at least in this picture. Here's what we found in this cohort study that had about 48 matched patients and controls. We found that on every single one of these individual examination maneuvers, our ME/CFS patients had a higher prevalence of an abnormal result than the controls. And on the next slide, I've just outlined the ones where the difference was statistically significant. So we saw limited ankle dorsiflexion in about 15%. Limited straight leg raise in about 70% compared to 30-some% in the controls. Upper limb tension testing was abnormal. The prone press up was abnormal. And these were really highly significant differences in most instances. This slide shows you that range of motion score from 0 to 11 at the onset of when we caused stretch. And you can see that it's as if the ME/CFS population was an entirely different group than the controls. Again, highly significant differences in the scores. Fortunately, on the right, you see the range of motion score just in our patients, and the purple, whatever color this is, violet, I guess, that was their score at baseline, and the black is where they were 24 months after being in this cohort study, where they received treatment of their orthostatic intolerance, their allergic inflammation, and many of them, probably 90%, received some degree of physical therapy. So these are not fixed restrictions. They improve in concert with the person getting better overall. And we don't know how much they cause the improvement, but they're certainly correlating. One of the ideas from this is that if a simple and relatively brief neural strain like a straight leg raise can provoke symptoms, then having that same range of motion on a prolonged basis, a repetitive basis, or an excessive basis beyond their usual range of motion in daily life might be followed by the same exacerbations and symptoms. Our experience over the last 20 years has been that if we treat these areas before advancing to any kind of more active exercise or activity, that improves the ability of patients to tolerate activity. So we have not tested that formally, but that's certainly been a consistent observation. Let me mention a bit about thoracic outlet syndrome, which we've been paying more attention to in our current cohort study. This is a disorder where you get compression of the neurovascular bundle as it passes through the space behind the clavicle and over the first rib to get down into the arm. There are three main types of TOS. The neurogenic accounts for about 95% of them. There are venous and arterial forms as well, and these are distinguished by the fact that the arm turns kind of ruddy and purple and swollen, and these patients can have clotting in these vessels. The main causes of thoracic outlet syndrome are crowding in this space as the nerves are coming out of the neck. So that can be caused by an extra cervical rib, by fibrous abnormalities and thickening of fibers that can compress the nerves. You can get the same thing if you've had recurrent clavicle fractures or repetitive trauma. And this is common in athletes who are using their arms for overhead activities like pitchers or volleyball players. This is a picture from the right shoulder of the spine, and then the scalene muscles that come out posteriorly in the neck. And the yellow, it represents the nerves that are coming down and competing for space, because sometimes the scalene muscles are too plump and they compress the nerves in the scalene triangle, or the clavicle can be compressing things, or the nerves and the neurovascular bundle can get compressed by the area under the pectoralis minor muscle. Here's the same view from the front to orient you. And the symptoms you get if you've got compression of the nerves is you get paresthesias, also the same, that term means numbness or tingling. And you can get weakness in the arm so that chopping is harder, taking the lids off things is more difficult. And most people get arm fatigue with their arms overhead. They can get some associated pain in the head and neck and in the shoulder or arm. We test for this with a Roos test or an elevated arm stress test, and sometimes an injection of lidocaine into the scalene muscles or Botox can be helpful to diagnose it and to treat the problem. Here's the elevated arm stress test that we're using in our current study. This is a 3-minute test where the person just stands in this candlestick position, opening and closing the hands slowly. If you've got thoracic outlet syndrome, people usually recommend physical therapy as the first step in management. But if that isn't successful, they move on to Botox injection to the scalenes. And if that leads to improvements, but Botox only lasts 3 months or so and the symptoms keep coming back, then many vascular surgeons will remove the first rib to make more room for this. We started being intrigued by the fact that our patients were, when we really asked specifically if they had difficulty with their arms overhead, often they didn't report this to us spontaneously because they thought everybody had the same problem. But these are patients who were saying, you know, when they're shampooing their hair, at least if they had a little bit more hair than me, their arms would get tired and they'd get numbness and tingling. But we started noticing as we started employing the elevated arm stress test in the clinic that people weren't just getting arm symptoms. Most of the patients that I'm showing in this life table analysis were people who first told us, yes, I have problems with my arms overhead. So we only tested that group, but 61 out of 64 of them developed some kind of arm fatigue or paresthesias within a median time of 20 seconds of arms up on this test. The other thing we were intrigued by is that this test could bring on systemic symptoms of lightheadedness, fatigue, and headaches. So we're now applying the elevated arm stress test in all of our patients, new patients in this study, to get a sense of the overall prevalence, at least among the adolescents and young adults. But this can be a cause of persistent fatigue, so it's important to look for it. Let me move on to the neuroanatomic problems. We had published a case series 6 years ago now, because we had 3 people that had moderate to severe ME/CFS symptoms, and nothing was working for them. But once we recognized that they had single or 2-level areas of cervical spinal stenosis, and that was treated surgically, we saw huge improvements in their overall function. We don't intend to suggest that this is super common, but it is something that can occur and needs to be recognized and treated differently. So let me tell you about one of these patients. This was the first of these individuals. This is a 15-year-old who had fatigue, lightheadedness, and brain fog. Past history was notable for some separation anxiety when she first started in school, but she actually was a very good student, liked school, and the anxiety had disappeared. At 12, she had a rotavirus infection that gave her, afterwards, she had fatigue, lightheadedness, fast heart rate, cognitive problems, myalgias, and very infrequent headaches. And so she was unable to attend school after her 10th grade, despite being a good student who only wanted to be in school advancing her education. She also had some free-floating anxiety that she knew was kind of irrational, but she couldn't make it go away. She had lightheadedness and brain fog. We did just a 5-minute standing test in her because of the intensity of her symptoms and the fact that we drove her heart rate up to 150 just standing still, leaning against the wall. She had headaches, fatigue, and shortness of breath. And we were afraid that if we kept her up longer, she would faint. So she had a minimal response to the entire bucket of orthostatic intolerance medications and didn't respond to the things her psychiatrist tried for the anxiety. Her physical therapist noted that she had some tightness in the back of her neck and said, "Can you take another look at her?" And we'd been seeing her for neurologic examinations every 6 months. And at this point, she had a thing called a positive Hoffman sign. And here I'm showing you how you elicit this. You support the distal part of the middle finger, you bend it down, and then you flick it. And what you're looking for is an abnormal contraction of the fingers, typically the thumb and the first finger. And that can be a sign of some sort of neurologic irritability in the neck. Often, if you see asymptomatic people with a positive Hoffman sign, they have on MRI some kind of bulging disc in the neck. Doesn't mean that they need surgery, but this physical finding is another one of the things that can be abnormal in ME/CFS patients. So we then looked at the family history, and frankly, that's probably what we should have paid more attention to, because her mother had a congenital cervical stenosis lifelong, and she'd undergone surgical fusions of the vertebrae in her neck at 34 and 43. So very early age for that kind of surgery because of degenerative disc disease. And she'd had 2 thoracic outlet syndrome surgery on each side as well. Her daughter's MRI, which we obtained after we did the Hoffman sign, showed a number of abnormalities. One was that normally you'd see this spinal fluid that's supposed to be, that's in white on this picture. You'd see about this much spinal fluid on either side of the spinal cord. Notice that by the time you get down to this 3rd cervical vertebrae, there's hardly any spinal fluid cushioning the spinal cord from being up against bones. As you follow this down, you see that at the C6 to C7 vertebral interface, this disc is bulging out. And because the spinal cord is so narrow, there's no space to accommodate it. Normally, the spinal canal would be 13 millimeters or more. Cervical stenosis is 10 millimeters or less. She was 8 millimeters up in this range, and she was down to about 6 or 7 millimeters at this point. The parents had found a spine surgeon that they knew from their church, Dr. Charles Edwards at Mercy Hospital in Baltimore, and he said, "Well, I don't know anything about that tachycardia and fatigue stuff, but this disc bulge is going to give you neurologic damage if you happen to get into a car accident and have a whiplash injury. So she elected to undergo a conservative artificial disc replacement without fusion. And here's this kid that had been essentially housebound for at least 3 years. Within 2 months, she took a job as a dog walker. She was able to exercise more without anyone encouraging her. She had a big reduction in the anxiety and tachycardia, and she started doing part-time classes. Surgery had been in November, and after 6 months, she was asking us, could she take a summer job in Colorado? I was a little apprehensive, but she went out there, and her job was to get up at 6 in the morning and saddle the horses so that she could take people out on a Colorado mountain trail ride, bring them back, unsaddle the horses, help clean them up, help with the cooking. So she was physically very active from dawn to dusk. And by September, she enrolled in college, went through in 4 years while working 1 night a week in a retail job and doing wedding photography on the weekends for a day. So she did really well just from this surgery. This is on the right, her standing test after surgery, which got rid of her POTS. And she's now been symptom-free for about 6 years, working in an international aid charity in Baltimore. That led to the next person in that series coming in. This young woman had been thought to have brisk reflexes by the neurologists that were due to her psychiatric medications, and that she had a functional or basically made-up gait disorder. We thought she had very brisk reflexes, and we got the MRI and showed that she had 2 bulging discs, which you can see here. It looks like the spinal cord is being pushed away, and it's thinned in this area. So she was down to a 7 millimeter spinal canal diameter at C6-7. So she had 2 discs replaced, and that area was fused, and had been at home needing a wheelchair to go to her doctor's offices with 2 weeks of PEM after each visit. She called me a week after the surgery and said, I don't think it's working. And I said, well, what do you mean? She said, well, I went home on day 2, and on the 3rd day, my mother and I took a 30-minute walk. And I thought, oh, perfect, we got it. On the 4th day, we took a 45-minute walk. And the 5th day, we went for an hour. And today, I'm really exhausted. So, she was just going way too fast. We had her pump the brakes and work up on her stamina, but she's now able to live independently again. The 3rd patient had you can see on this slide, just 1 level of disc protrusion leading to about an 8 millimeter canal diameter, whereas right above it, she had a nice 12 millimeter diameter. Here's the 12 millimeter section. Here's the area where the disc in this black was pressing asymmetrically on the spinal cord. So she had the disc replacement, and about 4 months later, here's a picture of she and her husband and a couple of friends in Vail skiing. The next slide she sent me was her being carted off by the ski patrol people because she'd torn her ACL. And we often joke that anyone in our clinic who can tear their ACL skiing has done very well from the standpoint of their ME/CFS. So this young woman did well for about 4 years, really good activity. And then the symptoms started creeping back in, and we were a little puzzled, but finally got repeat imaging. And we wrote this paper up with Dr. Edwards II, who's the surgeon, and his son, Charlie, who spent the summer working with us on research projects. Charlie's a senior at Vanderbilt University, hoping to go into medicine. And he did a great job on this report. So this came out in November. What we found on the repeat imaging is here she's got a normal canal diameter above the area of the artificial disc, but look what's happened. The lower part of the disc, this metallic stuff, had shifted probably during one of her falls skiing, and it was recapitulating not only the symptoms, but the spinal stenosis. So she had the whole thing repaired, and this time she had a fusion shown by these screws, and has again had a marked improvement in her overall function, which we measured using the Karnofsky score, where 100 is sort of as good as you could imagine feeling, the SF-36 physical function score, and the Wood mental fatigue inventory score, where higher scores are worse function. But just looking at the Karnofsky, here she is pre-op, here she is after the first operation, here she is when the symptoms return, and here she is after the second operation. We were leaning on work that had already been done by Dan Hafez. Dan had been a neurosurgical trainee at Hopkins when I was an intern, and he's practiced out in Milwaukee and Chicago. He realized that some people sent to him with the diagnosis of fibromyalgia and chronic fatigue syndrome actually had neurologic examination evidence consistent with some sort of cervical myelopathy, some damage to the cord. So he had a huge series of 270 with fibromyalgia, 20% of whom had Chiari malformation, where the cerebellar tonsils descend into the foramen magnum, the hole at the base of the skull. And 46% of them had a narrowing of their spinal canal diameter at C5-6. So they had cervical stenosis. He then took a group of these patients who had agreed to surgery and compared them to a group that didn't have surgery, either because they were milder or insurance wouldn't cover it, or they just were apprehensive. And you can see very clearly that on measures of improvement in fatigue, exertion, concentration, headache, pain, dizziness, and nausea, the ones who had surgery, who were probably sicker in the first place, had better improvements at the 1-year point than the people who had not had surgery. Let me bring this towards a close by talking about a 25-year-old that we saw during the pandemic. This young woman described herself as unathletic as a child. She had a lot of clumsiness and poor depth perception. She was very flexible. She was able to do a lot of tricks, like she could lie on her belly, and her legs would come up behind her head, so the feet would go past her head. So she's super flexible. She developed some tachycardia as an adolescent, had some seasonal allergies, and started immunotherapy or allergy shots at 22, but had a mast cell type of reaction because she would get itching, congestion, and throat closing, needing a week of prednisone or something like it with each increase in the dose of immunotherapy. So by 18 months into the immunotherapy, she was only at half of her usual full dose. She was working full-time as a bone marrow transplant nurse when she started getting ME/CFS symptoms in March of 2019, when she was 23. And these symptoms progressed over the next 18 months. I'll show you them on the next slide. And she would get big flare-ups every 1 or 2 months that would last up to 2 weeks. And these were becoming so frequent that she was unable to work by 2020 in July. So these were her initial symptoms. She had fatigue that was present, worse with activity, awakening unrefreshed. Everybody's familiar with that. She had headaches at an 8 out of 10 level. She had neck pain. She had lightheadedness with a heart rate that would be 140 beats per minute at work. Brain fog. She had arm fatigue with arms overhead, so features that looked like thoracic outlet syndrome. She couldn't do her own hair. And she had a bunch of other symptoms like night sweats, some right-sided numbness and tingling. And when she went to the ER at Emory to get this looked at, they said this is probably a conversion disorder. She had a lot of other problems, including a new sense of overstimulation that she didn't understand. The symptom that really caught our attention was that her neck pain was worse with neck flexion. She had used a neck traction device that you put over the door frame, and pulling upward on her neck, she felt better. Anytime she rotated to the side, she felt a crepitus or grinding in the neck. And most importantly, her head and neck felt heavy and unsupported. And those are features that we see with ligamentous instability at the skull base. So we met with her by telemedicine, and we thought, gee, she probably has hypermobile Ehlers-Danlos syndrome. She certainly meets ME/CFS criteria. She has well-diagnosed POTS. She had some irritable bowel syndrome. She had all these allergies and mast cell activation syndrome. She had evidence of neurogenic thoracic outlet syndrome. And we suspected this craniocervical or atlantoaxial instability. Here's a picture of another patient who's got a nearly normal appearance at the skull base. Here's the clivus and here's C2. On the next slide, I've drawn in the clivo-axial angle, which is one of the metrics that we look for. That should be about 150 to 170. Here's her MRI that she sent us. She had a very unusual angle here, 130, and her brainstem was sort of bent forward, which probably added some neural strain to this part of the brainstem. The other thing that jumped out was she had an abnormal Grab-Oakes measurement, which is drawn from the base of the clivus to the back of C2, and you draw a perpendicular to where the tissue stops. Normal is less than 7. She had a 9 millimeter distance, if you imagine it from here to here, and this pannus formation tends to occur in people with loose ligaments. So we thought, well, until we get a chance to examine her, let's at least put her in a hard cervical collar like the one shown in this picture. And with the hard collar on as a diagnostic trial, she had immediate resolution of her headaches and neck pain. She had enough energy to do consecutive hours of activity and errands. Lightheadedness was better, sleep was better, her speech was clearer. The sensation of light sensitivity and sensory overstimulation was better. And when she actually misunderstood the instructions and took her collar off 2 days before we saw her in clinic, and she had a return of all of those symptoms. When we examined her, she did have the evidence of joint hypermobility. Her Beighton score was elevated. She had a number of other things we see, including these piezogenic papules at the heels. Her reflexes were super brisk. Her Hoffman sign was also positive. And she didn't have a gag reflex, which indicates some problem in the upper cervical spine or skull base with compression of the nerves there. And she had the thoracic outlet syndrome test that was positive. So when we suspect this instability, we do dynamic imaging. So you can't pick it up with a plain CT or plain MRI where you're just lying in the scanner. So with the C-spine CT scan, the technician rotates the patient's neck to either side. And she had, and they do flexion and extension, she had 5 millimeters of movement in the frontal plane at the skull base when normal is less than 1 millimeter. And she had excessive rotation of C1 on C2. Normally that should be less than 38 degrees. She had 43 and 45 degrees of instability. So that confirmed with radiologic objective findings what we suspected. What's probably contributing to symptoms when you can turn your C1 too far on C2 is you narrow the space within which the spinal cord is sitting. You probably are wrenching it like a wet dish rag, so that interferes with neural transmission through this area. And another potential problem is we've drawn in the vertebral artery, which comes up through a hole in the lateral aspect of each vertebrae. There's one on this side as well, but we didn't put it in this illustration. But if you can turn C1 too far on C2, you can see that you can pinch off blood supply, usually thought to be beyond 41 or 42 degrees of rotation. So Dr. Fraser Henderson in the Washington, D.C. suburbs has been a leader in looking at these problems, especially in the group that have Ehlers-Danlos syndrome. In one of the papers where we looked at the frequency of syncope or pre-syncope, these are people who before surgery in white had fainting once a week, multiple times a week, or daily. And look at the shift in the frequency of those problems after stabilization surgery. Dr. Henderson published a recent paper on craniocervical instability where he did occiput to C2 fusions. This young woman had the occiput to C2 fusion and everything improved. She was back to working part-time as a research nurse. She still had some leg heaviness because she had one of the problems we talked about last week, May-Thurner compression of the common iliac vein, but she just had that stented about 2 months ago, and we're awaiting feedback on how she's improved. So these neurosurgical problems can't fix everything wrong with the patients, right? She still has mast cell activation and Ehlers-Danlos syndrome, but much, much better functioning. And there was nothing psychological about her problems. I want to make sure people don't think we're recommending this for everybody. I just think that these problems can occur in our patients. They mimic the ME/CFS symptoms, and they ought to be looked at in those who have no responses to any of the standard therapies, and especially if they have problems on their neurologic exam. I mentioned I'd say a very little bit about mast cell activation. This is just a picture of some of the facial flushing that we'll see in our patients. You can see in this girl that her whole face is bright red, and she's got a rash in the chest, blotchy rashes where people scratch themselves, hives, erythema affecting the ears and the face. These are the things that we're paying much more attention to these days on the physical examination, and the mast cell treatments are often very helpful in getting people more stable. So in conclusion for today's session, the symptoms of ME/CFS we know can be provoked by application of a neural strain to the limbs and can be treated with, with manual therapy techniques. Over 75% of adolescents and young adults with ME/CFS have reduced range of motion of the limbs and spine. And that can even occur when they're hypermobile, so they get focal areas of restricted range of motion. Treatable neurogenic thoracic outlet syndrome is another biomechanical contributor to ME/CFS symptoms. These neuroanatomic problems that I mentioned can affect a subset of patients and probably should be considered in those who have refractory or severe symptoms, especially when we do a careful neurologic examination. And just lastly, mast cell activation is another treatable contributor to ME/CFS symptoms. And we think the same things are likely to apply to long COVID, at least among the patients we've evaluated. It's just that many of the long COVID researchers have not been applying the lessons of ME/CFS to their patients. I'm going to just end with the group that has helped us do this work over the last 30 years. The Sunshine Natural Wellbeing Foundation donated enough to endow a professor's chair that has allowed me to see patients without the time clock being on. The Boyce and Caldwell families have contributed to endowed funds that will have helped us hire more patients. We've had a really great team of physicians and nurses and research assistants, some fantastic summer students, a number of others who do fundraising like Emily Steffensmeyer, and really many of the families and patients in our clinic have sort of kept this process alive. So we're incredibly grateful to everybody who has contributed. I'm going to stop there and see if we've got time for questions, and we can go another half hour of tests
Awesome.
if that's the case for you
Yeah,
guys.
that would be great. We're so first of all, that was great. Our team behind the scenes was joking around that you were showing some of my MRIs because I have a lot of these conditions, and I'm actually going to be getting surgery next Wednesday, an artificial disc replacement, and I'm going to be very curious to see what happens after that.
So that raises an interesting point. If you like, the first patient I showed had a very abnormal clivoaxial angle. She had the congenital stenosis and she had one disc bulge. We wondered initially, do we have to kind of open up the entire spinal canal? Do we have to fix that weird clivoaxial angle? We elected with Dr. Edwards to do the least invasive thing first, and that was all she needed. And she's, 5 or 6 years out from the surgery and doing beautifully.
Yeah, that's my plan, thinking about all the different pieces of it.
Yeah.
I'll start with the easiest and then go from there.
Yeah, that patient I should call out because she tried to give me a heart attack. She decided that her 2 sports after surgery would be salsa dancing with her husband and rock climbing. So be good to your doctors.
Okay, so we're going to do the Q&A a little bit different this time. We are splitting it up by topics, and we're going to have our team members jumping in here to ask questions from a certain topic. So we'll start off with Rochelle talking about some of the first topics of the talk.
Okay, so I'm trying to make sure I've got get these, reading off the ones that were kind of marked to start off with. And so there's one on here that I think is going to be somewhat relevant for a lot of us especially with long COVID. And she says, I've lost a good amount of my use of my hands since having COVID and long COVID. My long COVID is fairly severe, and I'm extremely limited in what I'm able to do now. Is it possible to develop a thoracic outlet syndrome as a result of this without any of the repetitive motion issues? If so, can it be acquired?
Yeah, that's a great question. We don't know why thoracic outlet syndrome symptoms start happening at a certain point, but they can, and who knows what leads to that change. Something changes as the nerves are traversing from their exit point in the cervical spine down through the under the clavicle and into the arm. Maybe it's the position that people are in when they're sick. Who knows? But if you've got those problems with arms overhead, a lot of the patients feel that these things have come on so gradually that they don't tell us. So I had one girl who we suspected might have this, and I said, how do you do with activities that involve reaching up, like, and it was around Christmas time, like putting the ornaments on the Christmas tree. Her parents were across the room and they fell off their chairs laughing. And I thought, well, I didn't say anything funny. What does she not like decorating the Christmas tree? And they were laughing even harder, because this girl orchestrated everybody in the family to decorate the tree. She loved doing it, but she knew that every time she put her arm up, she'd be tired for half a day. So she didn't even mention that to her physicians. Others have problems holding their arms on the steering wheel at 10 and 2, and they typically hold the steering wheel at the bottom at 6 o'clock, because anything that involves arm extension, like emptying the dishwasher, putting the clothes up on the rack, those things will cause symptoms. A lot of the girls who have longer hair will bend over in the shower rather than reaching up to avoid provoking these symptoms. So we think it's a big problem. We think it's highly prevalent, and it's just another example of how the physical examination can be quite abnormal in patients with this illness. And it's baffling to me how anyone in the early 90s said, yeah, these are all people with a normal exam. Nonsense.
There's also a couple that are questions that are somewhat related to each other. And so I'll kind of like group them together. I won't read the questions specifically, but for things of like neurogenic thoracic outlet syndrome with issues traveling alongside with issues of instability and versus stenosis, but also things like is scoliosis also a risk factor for that, as it's part of the overall structural issues that could lead to suspected thoracic outlet.
So the one thing we suspect, and this has been written about, but there's not a lot of information directly about it, is everybody who deals with Ehlers-Danlos syndrome suspects that neurogenic thoracic outlet syndrome is much more common in that population. So there must be some connection between instability in the spine and thoracic outlet syndrome, but it hasn't been a topic that people have spent a lot of time on, unfortunately. But I think we're trying to get these papers, another paper on TOS with Charlie Edwards into print that draws attention to the need to look for this in the ME/CFS population.
And then one last one in here that's, again, grouping several kind of together. The possibility of children growing out of ME/CFS and the possibility of long COVID and not, but also otherwise, is surgery always going to be something that is recommended when that starts to be like intransient? And then how much does that improvement just more spontaneous, and how much of it is going to require intervention?
Yeah, so I think, let me make a couple of comments about that. We are not recommending this just as treatment of ME/CFS. It really has to be treatment of confirmed, standardly defined instability with obvious radiologic metrics, symptoms that have been unresponsive to conservative measures of medication, treatment, PT, everything. And you often want some sense that you're going to see improvement when you stabilize the neck with a hard collar. We do have a number of patients that get better spontaneously. I think Kathy Rowe in Australia has the largest series of over 700 adolescents that she followed over time, but the average duration of illness was something like 8 years among those who improved eventually. So it's not a brief illness. You know, we were taught when I first got involved in this field that the received wisdom was that, oh, just wait 2 years, they'll all be better. And that's clearly nonsense as well.
Was that the last one, Rochelle? Your topic? Okay,
For now, at least, we'll see if more come up.
we'll come back around. Okay, so then the next topics were the cervical stenosis and CCI. One of the questions that came up is, do you have ideas about the mechanism whereby the spinal stenosis causes ME?
So we don't know exactly, but in each of the patients that we saw with spinal stenosis, it was the front part of the cord that was being compressed. And if you've got something pressing on your spinal cord, you better have some kind of major alert message to the brainstem centers that control the physiologic responses. Because if you don't, there's something really wrong. You've got a major threat to the organism if you've got something poking on the spinal cord directly. So it's likely that it's some combination of nerve messages caused by that compression. In all of the patients that we reported, everybody had some improvement in anxiety. At least it was what they called anxiety. I think it was the fight or flight response that was being generated by pressure on the spinal cord. How that then dovetails with all of the ME/CFS symptoms, I think is a little unclear, but we think that a big factor is that if you can improve the orthostatic intolerance one way or the other, people generally feel better.
Yeah. Another set of questions was about treatments that don't involve surgery. So do you have any?
So we have some patients who have excessive rotational angulation of C1 on C2 up to 49 degrees, but their function is pretty good. So we've tried to send them to physical therapists. They might wear a collar at night to stop them from moving their neck excessively during sleep. There are reports of clinics around the country where they use prolotherapy, which is an injection of some kind of substance that tightens up the ligaments. Problem is that most of these are for-profit clinics, and none of them have been interested, because it's their business model, in figuring out whether these treatments work or not. So all we've got there is anecdotes, and it would be good if one of these approaches was used in a study in an academic center where the academicians have no vested financial interest in whether it works or not, but they could assess it properly. So I think that's what we'll need in order to know whether one of these less invasive techniques might work.
Right. Yeah, actually, I live in Denver, a few miles away from the Centennial Schultz Clinic that does the prolotherapy. But yeah, I haven't seen research into outcomes.
And by the way, we need in more conventional academic sites, we also need to do better with looking at the outcomes of our patients who've undergone these surgeries.
Yeah. So just kind of a broad question for people on the webinar who think that they might have these conditions, but they don't know where to get started, or, you know, maybe their clinician doesn't know about any of these conditions. Like, how could people get started? Is there, you know, certain things that you could ask your doctor for?
Yeah, so if you just get the plain MRIs, right, you might be able to see a bulging disc or a Chiari malformation, but they don't pick up these more subtle things that are only picked up by excessive motion. So you have to find somebody that has a seated upright MRI. We do an MRI in flexion and extension, and then we have a couple of radiologists in the Baltimore, Washington area that do the CT scans properly. But I can't even get that done at Hopkins, right? So you have to show that you've got a lot of interest in this patient population, and that you're willing to take the time to do all the detailed measurements. So it is difficult for people to access this kind of care. Once you've identified somebody as having instability and they haven't responded to the conservative measures and their pain and functional disturbance is significant enough, there are only a handful of surgeons who are willing to do these procedures around the country. So these are early days, and medicine is often a very conservative profession where people want to see randomized trial evidence that it's going to work. People are sometimes unwilling to operate on people with lax connective tissue because they have such poor healing. So there are a number of factors that lead to this being a little bit tougher than it should be, I think, to get access to care. But I think it's changing. I think as we're all trying to publish more information to bring this to everybody's attention, we're seeing more papers come out on what are the proper radiographic metrics for considering surgery, how symptomatic should people be, and what are the things to do technically during the procedure to make sure it comes out right.
Great. I think I'm going to pass it off to Shelley to ask a few questions.
All right, awesome. This has been so great, Dr. Rowe. I have 3 questions having to do with mast cells.
Okay.
They're kind of similar. The first one is I'm going to give you the first 2 together. What do you suggest for mast cell stabilization aside from pharmaceuticals? And then someone asked for your general medication recommendations for mast cells.
So I've learned a lot from our colleague, Larry Afrin, who's a hematologist oncologist who's really paved the way for work on mast cell activation. He does a tremendous amount of teaching of his colleagues. And Larry's first, second, and third points are find out what's triggering the mast cells. Is it specific foods? If so, eliminate those. Is it odors? So we had one patient who had, for a long time, had a lot of trouble every time she took a shower. She just felt miserable in the shower. And we thought, oh, it's because the hot water aggravating your orthostatic intolerance. Then she read something in the New York Times about plastics, and she took out the plastic shower liner and replaced it with a linen one. And for the first time in about 10 years, she had major improvements in her ability to tolerate the shower. So it wasn't the orthostatic intolerance alone. It was the fact that her mast cells were being stirred up by some off-gassing from the plastics. And that process can be quite different for each person. Some people with mast cell activation get very symptomatic with leftovers, because the leftovers that are put in the fridge, the bacteria on those foods can generate histamine. Others are very intolerant of high histamine foods or anything that's fermented. Red wine, chocolate, so you have to look at, there are websites for low histamine diets. They're really quite complicated, but if you can identify specific foods that really stir up symptoms and eliminate those from the diet without nutritional problems, that is a good first step. The medications we use for mast cell activation are actually quite benign. And I want to come back to the issue of definition. But the main medicines are what are called H1 antihistamines, things like Claritin and Zyrtec and Allegra. And then the H2 antihistamines are drugs like Pepcid or famotidine, which bind to other histamine receptors. And another class of antihistamines are the older tricyclic antidepressants like doxepin, nortriptyline, amitriptyline. Sometimes they're a bit tough to use, but sometimes they can be really good. And doxepin is a particularly sedating antihistamine with super strong antihistamine effects. We often use that at night. Then you can pick drugs that somehow prevent the mast cells from dumping out all their contents, which include histamine, but hundreds of other substances. So the big one there is cromolyn, oral cromolyn, but things like montelukast or Singulair and some of the other drugs like that can control those effects. And different supplements can be helpful, like quercetin. Aspirin for some people in low doses is helpful. Vitamin C can be helpful. So you have to spend a lot of time seeing what each person will respond to. Some people are trying N-acetylcysteine as another drug that might have mast cell controlling effects, and some are investigating it for both fatigue and brain fog as well. So there are a number of things that are available to people, often without prescription, that people can play with in conjunction with their physicians. The diagnostic question is a tough one because the academic allergy community has followed very strict rules for diagnosing mast cell activation. They want to see a 20% increase above the basal tryptase level during a flare. Well, that means that if that's the only way you get diagnosed, most people in the underdeveloped world can't get a tryptase level, can't get diagnosed, and then can't get treated. Dr. Afrin and a number of us have written a counter to the consensus view of mast cell activation, which says you need to have a consistent clinical story and a response to one of these medications I just mentioned, plus or minus some biological evidence of an elevation in histamine or one of the other mast cell byproducts. But it's a much more patient-friendly approach that doesn't restrict the number of people who could potentially be treated the way that the academic consensus one definition does.
All right, thank you so much. That was super helpful. I really appreciated the anecdotal story about the woman with the plastic shower liner. I think all of us are going to be thinking about anything that could be triggering us. The next question about mast cells was just, can you share a little bit more about how it relates and may be aggravating some of these spinal issues?
So when the mast cells, they're really a part of the primitive immune system, right? They're what we use to tackle some organism that we haven't seen before. So if you don't have antibodies to something, the mast cells can sense that there's an invader. They dump out their contents. The histamine brings other white blood cells to that region, and they can possibly gobble up the infection. If you've got a lot of mast cell activation, if they've been stirred up already, and then you get something like COVID, Dr. Afrin has proposed that that is a trigger to the hyperimmune response that the mast cells can orchestrate in response to a new infection. They also seem to play a role in long COVID as well. So we use a lot of antihistamines and similar type medications in our long COVID patients, especially if they have a strong allergic type history. One of the theories that's out there, and I don't know how much credence to give this, is that because the mast cells have enzymes in them that can break down proteins, some people have speculated that you can go from not being hypermobile to being hypermobile due to the effect of mast cell degranulation and these enzymes on the ligaments. So that's an interesting question. It would be nice to have better data, but there are some strong opinions that that must be how some people become worse and worse over time.
Yeah, I think that is an important question for a lot of us trying to figure out where we are on our diagnostic journey. Thank you so much. Really appreciate that.
Sure.
Tess, what's next?
We will go to Ellie next.
Hi there. This is a comment from Dr. Hassan Abdallah. I think you know him, Dr. Roos. He says, great presentation, and can you tell us about your experience with neurosurgeons, differing inputs about cervical instability and the effect of Chiari type on CCI?
Yeah, so I think this is another area where people are at different points of adoption of and their agreement with the new data, right? As we talked about before, there's a range of people who are super skeptical. They want to see 7 randomized trials before they'll change their practice. Others of us see some reasonably coherent information. We're trying to help our patients at an early point. And that's a kind of dynamic in medicine. And so we don't have people at Hopkins, for example, who do this kind of surgery for our patients with instability. At least they don't do a lot of it. Maybe they do it when they see certain patients, but not because they have ME/CFS or Ehlers-Danlos syndrome. So it's been a big problem finding people who can properly evaluate and carefully treat them. And I think Hassan knows some of the individual players in the region, but these guys are really, I think, very brave in tackling this problem when much of the neurosurgical profession is criticizing them for doing surgeries that are too aggressive.
Okay, and we have a question about scoliosis. Is that a predisposing factor? Can you explain that a little bit more?
So it may be that the people who have laxity of their ligaments, like joint hypermobility and Ehlers-Danlos syndrome, are much more likely to have scoliosis. So that may be that it's the underlying connective tissue laxity that predisposes them to both. We don't have a lot of our craniocervical or Chiari patients who have bad scoliosis, and that may just be a sampling error. But Ehlers-Danlos syndrome can predispose you to Chiari malformation as well as the ligamentous instability.
Do you have any more questions, Ellie?
No.
Okay, we'll go to Michael then. Do you have any questions?
I've got a few that I picked up from the chat. Yeah, excellent talk. Thank you very much for doing this for us. The
Sure.
first one is there a role for low-dose naltrexone in these populations?
Yeah, we use a lot of low-dose naltrexone, especially in our EDS patients, because it's often very helpful for their pain. Chronic pain is a big problem in that population, maybe because the ligaments are so loose that their joints are sort of excessively movable. And low-dose naltrexone has been studied more formally in fibromyalgia patients. And I think we all find that it's really quite safe to use. It's one of the better drugs that where you don't expect major side effects. There are debates about how we should start it. Some people say, you start at 1.5 milligrams, and in 2 weeks you can go to 3 milligrams and then 4.5 milligrams. Others feel that races past effective doses that are often quite low. So some people start at 0.5 milligrams and go up weekly until they see a benefit. And then the sweet spot might be between 1.5 and 3 milligrams per night. So again, those are differences of opinion that we could settle with better studies and more coordinated randomized trials. But for now, it's safe enough to use. We find that it can occasionally give a nice overall benefit, and we've used it in our long COVID patients as well.
Okay, and the next one is, are muscle biopsies ever useful in the diagnosis of ME?
We haven't used them. I think they're more of a research tool as we try to understand what's going on and whether there might be mitochondrial metabolic activity that's abnormal, but we have not typically seen any evidence of true muscle fiber abnormalities in the ME/CFS patients.
Yeah, I think this question is probably coming from, there was this recent study by Rob Verst in the Netherlands, which showed some interesting findings in the long COVID population. The next one, this is interesting. I'm interested in the answer to this. So does any of your research hint as to why lymphatic drainage techniques like the Perrin technique might be benefiting some patients?
Yeah, it's unclear how much you can separate the lymphatics from the fascial tissues, from other areas of muscle tightness. I think if you're doing lymphatic massage, you're doing more than just targeting the lymphatics. You have to be touching other tissues. And so, as the osteopaths say, to touch is to treat. So you're not quite sure what you're doing, but you're probably changing more than just your targeted therapy. But I think, we again, Ray Perrin's techniques have been effective for some And we just need more study of that and comparison studies to see which gets more people better in a faster manner.
Happy for me to continue. I've got several more questions if we've got time.
I'm good.
Let's
You
do
good?
maybe two more.
Okay, so is there a role of drugs that support endothelial function, such as diosmin, hesperidine, sulodexide, and statin, things that support vascular tone and which may be dysfunctional in people with POTS, ME, or long COVID?
I think people have started to look at those, and it makes sense that if you've got something that could cause some vascular constriction, that ought to make people with orthostatic intolerance a bit better. I'm not aware of too many formal studies of those items. The statins can have an anti-inflammatory effect on some people. So we have the occasional patient who gets put on a statin for their hyperlipidemia, and they notice some other improvement, like in their cognitive function or their general energy. So again, it would be lovely to have big coordinated trial networks like they have in pediatric cancer or in HIV, with hundreds of ME/CFS clinicians around the country doing these formal studies, so we could get to a more effective treatment faster.
Okay, thank you. And probably the last one is, what's the role of glucose sensitivity in the worsening of POTS? And is there a role for ketogenic diets or the use of metformin?
I'm not sure about the glucose question. I'm no expert on that. We have occasional anecdotes about patients who feel better on a ketogenic diet, but it's a bit of a struggle. And again, it probably ought to be studied more carefully. What was the last bit of that?
It's whether metformin might be of use in given this sense of some sort of glucose sensitivity.
Maybe, there was the report recently of metformin as a way of preventing long COVID. It didn't do it for everybody, but it was statistically significant. So we've been using it in some patients who have acute infection for 10 days to try and limit the likelihood of long COVID. And anything that works in the acute phase, you'd wonder if it would work in the long-term phase to also do something beneficial. So that's a good candidate for another trial.
All right, thank you very much.
All right, I'm gonna pass to Rochelle, and then if there's a little bit more time, we'll come back for a few more from Michael. But we had to point out that if you want to see what MCAS looks like, that Rochelle has gotten red throughout the webinar. we're noticing that she's a little bit more pink now. And
Yeah.
yes, I'll pass off to Rochelle to ask a question.
Yeah, I'm definitely blotchy, and I'm trying really hard not to itch because I don't just get hives all down me then. And yeah, got other things going on too. So, but which made me also a question that popped up here towards the end, and it was asking about idiopathic intracranial hypertension. And its relation to any of these patients. In the question, they also say it's been found in MS, but there's also other possible signs of it that are, sometimes often dismissed on MRIs, but are not, they're just like, oh, well, it's a partially empty cella. Unless they have other symptoms, don't worry about it. And you're like, well, why do you think I got an MRI? Or also giant arachnoid granulations, which they're like, well, we don't really know what they do, so it's probably fine. If you have any comments on any of those kinds of findings, especially with the IIH.
Yeah, so with idiopathic intracranial hypotension, so low pressure, it's often associated with a tear in the dura that keeps the spinal fluid in place, right? So if you get a tear in the dura, and that's much more common if you have Ehlers-Danlos syndrome, to get a thinned out dura that can spontaneously leak, then as spinal fluid leaks out faster than it's being made in the brain, then the brain loses the suspension that fluid provides, and the brain sinks down against bone. And typically people with bad intracranial hypotension feel miserable when they sit upright for more than a few minutes. and they get a just progressively worse headache, and they have to lie down, and they feel better lying flat. That's the opposite of intracranial hypertension, where those people need their bed elevated, they need their head up, because when they lie flat, they get an excruciating headache. So we can see both types of intracranial pressure abnormalities. The low pressure is much more common in those with Ehlers-Danlos syndrome. The high pressure is common in people who have in some sort of obstruction to outflow of blood from the brain. And there's more work by our neuroradiology colleagues on that all the time. One of the leaders in that is a guy named Ferdinand Huey, who's a former Hopkins neuroradiologist who saw the light and moved out to Hawaii.
So yeah, that was kind of like trying to like look in on some of the questions on that and trying like the intermittent effect of like going back and forth between the hypo and hyper. There's also that little fun little balance that is always trying to find that right spot. But I think that's all the I'm losing focus myself. Otherwise, I would start getting into the glucose question. My thing. That's kind of my jam. But I wouldn't be coherent. I don't think right now. Kind of like I'm losing my. Yeah.
Yeah.
Plus, I've got a hard stop in about 2 minutes too.
Okay, great. So yeah, good time to wrap up then. But we did chat with Dr. Rowe before this, and he said that we'll find a way to answer more of the questions that people have put into the chat for the part 1 and part 2. So look out for that. remissionbiome.org, sign up for the newsletter, and we'll include that with one of the future newsletters. So I would like to thank Dr. Rowe for another excellent presentation, and we really appreciate you spending your time with us. And
No, great. Love doing this. So anytime.
Great.
Take care.
All right. Bye, everyone.
Bye.